you, as Dr. Rajesh Kapoor is, you must all know, he's a leading cardiologist and chairman of interventional cardiology at Medanta, the Medicity, which is at Gurgaon. Dr. Rajesh Kapoor was already been honored by our honorable Minister of Health by Dr. Bharti Pawar as an India's most promising cardiologist. Not even that, Captain Arvinder Singh also awarded Dr. Rajneesh Kapoor as an achievement in the field of cardiology. I request and over to you, sir, so that you can proceed this webinar, which is dedicated on OCT and how AI is really helping us.
Yeah, thank you, Sunil. So we all are here to start this online session, which is focusing on OCT and its usage in coronary PCI. We all know that this is coronary imaging is vastly helping us. It has improved our outcomes. It is giving a lot of benefits, advantages. At times, we decide after imaging that we need a rectified step. Some rectification is required. Either we go ahead and seal the dissections at edges, or we further go ahead and we feel that it is still under expanded stent. We all know that under expanded stents are not good in the long run. So, like this, I feel in our practice, imaging is really doing a wonderful job. And OCT is one part which is now integrating a lot of AI into it. So once we actually take a OCT catheter, take a shot through a OCT catheter, uh, the kind of information this OCT machine gives us is tremendous. Not only in terms of the vessel caliber, it also tells any calcifications, the arc of calcifications, and nodules. And also we decide the length and the stent size based on the AI given dimensions on the OCT. So this is how it is. I think it's really wonderful. And frankly, I tell you, we use almost, in 80 to 90% of our PCIs OCT. So, and I think it is very comfortable after using OCT that we decide, and we have felt over the time that our outcomes have also definitely improved after OCT has, we have started using it in our practice. So I open this session. I think there will be, multiple presentations. But firstly, I think I'll also invite Pankaj, who's very dear friend from Bhopal, and we all know that he has been tremendously involved in coronary imaging. Very real good job he has done. He has also, published a book regarding imaging. So welcome, Pankaj.
Thank
Welcome. Let's
you.
together run this. Yeah. Over to you.
Okay.
Pankaj, go ahead, say a few
Just
words.
sharing my screen.
I think, yeah, you have
I'm
to.
audible?
Yeah, you're audible. You have to give a first presentation.
Yeah.
So over to Pankaj for his presentation.
Okay. Okay. I hope I'm audible and visible and my slides are seen too.
Yes,
Yes, sir.
Pankaj. Yes.
So I'll be giving a short presentation about what 7 features of Ultron 2.0 I like the most and how we can utilize this technology in our day-to-day practice in optimizing the results of our angioplasties. I think that what we desire in any imaging modality is 2 or 3 things: that it should be quick, it should be user friendly, and it gives us enough information which we can use. And Ultron 2.0 has all these good qualities. It is quick, it is easy to learn, and it is very user friendly. The first and foremost thing which I like about Ultron 2.0 is calcium assessment. Now, whenever we are seeing any calcium in Ultron 2.0, whenever the AI detects calcium, it is visible in the form of orange color. The orange color is for the calcium. It automatically highlights the calcium above the threshold in orange. You can see the arc of the calcium per frame is indicated with the orange arc on the cross-sectional view. On the L mode, we can measure the length of the calcium. Wherever there's orange color, that is the length. And also, if you see, open the OCT analysis panel to see for the maximum thickness of in this frame. You can see this white arrow indicates where in the complete circumference, where is the maximum thickness of the calcium. This is indicated by the white triangle on the cross-sectional view. Also, the main beauty is the software responds dynamically to the threshold. That means, suppose I'm intent to see only calcium more than 270 degrees. So I'll change the threshold to 270 degrees, and the software will respond dynamically to that. On the other hand, if I want to see only 90 degree calcium, all the calcium more than 90 degree, I will set the benchmark to 90 degree, and then the entire coronary artery, wherever there's more than 90 degree calcium, it will be visible as orange color, both in the cross-sectional L mode as well as in the angio also. It also has a good angio co-registration. As you can see here, the orange color is marked not only in the OCT, also on the angio also. Thus, you can pinpoint exactly where is that severest calcium, because it will be highlighted in the orange color on that particular on the frame in the on the segment in the angiography. So that you can utilize your resources much more in that particular subset. For example, I plan to use an IVL. So I'll switch the benchmark to more than 270 degree, and wherever there's more than 270 degree, it will be highlighted in my angio. So I can set the IVL, the emitters exactly at that point, so that I can utilize my maximum energy at that particular area which has a maximum calcium. So it not only quantifies calcium, it also has a good angio co-registration. So it's a very wonderful device to see for the calcium and see for the how it is being evaluated. Now, second is in 2.0, it detects EL automatically. In Ultron 2.1, this was a problem that EL was not visible, but here EL is detected automatically. This is a simple case of RC. I want to do angioplasty. Now, whenever I do OCT pullback, it automatically calls out for the minimum lumen area to quickly locate the lesion of interest. So this is the minimum lumen area, as you can see here. Now you can scroll the cursor up, forward and reverse to see for your landing zone. And how to identify landing zone on OCT? Wherever you see EL, maximum EL, that is the most healthy zone. That means larger the circumference of EL visible, that means least is the plaque burden, and so better is the landing zone. And EL is visible at white dots, both in the cross-sectional view as well as in the L mode. Here you can see why this white dot, that means in this artery segment, the EL is completely visible. And whenever the EL is visible more than 180 degree, the software will automatically calculate the vessel area. And you can see in this frame, the EL is visible for almost 270 degree. So all these dotted marks is the media, or you can say EL. It says that your vessel area diameter is 4.9. It automatically calculates the vessel area provided the EL is visible for 180 degree. So angioplasty, marking your proximal landing zone, your distal landing zone is very easy. Just see the region of interest, scroll the cursor forward and reverse. Wherever you see maximum EL, bookmark the segment. Same thing you have to do in the proximal segment. Measure the length. This will give you the exact size. And this is how you can see. So there's no manual measurements are needed. Everything is visible in this cross-section area also. Yes, you bookmark that. It will show you the plaque burden. It will show you the vessel area. It will show you minimum lumen area. It will show you the diameter of the vessel also. So it automatically calculates and displays for a quick stent selection. The sizing card, if you open that on the OCT analysis panel, it summarizes all the automatic measurements for the current stent plan in a glance manner. So this makes a procedure very easy, convenient, and you can do exactly precise angioplasty. You know your distal landing zone is which diameter, proximal is which diameter. Marking this is very easy. You can bookmark that segment and quickly it measure the length of the stent to be used. The third important feature, a very important and very useful feature, is dynamic angio co-registration. With this feature, we can do live stent implantation looking at the OCT screen. We may not look at the angio screen. First, you have to do manual co-registration. For this, you have to drag this forward and backward. So that, first of all, the crux of good angio co-registration is the vessel should be straight. If it is rotated or turned away, then the co-registration may not be that accurate. For that, just scroll this orange mark forward and reverse so that the vessel is straightened. Once the vessel is straightened, you have to bookmark click 2 points. First at the at the point where the guiding tip is visible, and second at the point where the distal tip of the guiding wire, that means where the rhodiopic portion is starting, you click that point. So the trace path will follow the center of the vessel automatically then. This is how you can just confirm that. So the trace path is following the center of the vessel. It suggests good angiocorregistration. So that is doing is very easy. Now, once you have done that, and you can zoom it almost 400 times, your area of interest. You bookmark that segment, your proximal distal landing zone on angio, which will be angio, and just you can zoom it almost 400 times. So that now you can focus and mainly on your area of interest, because it has zoomed almost 400 times. Now you can see in angiocorregistration, you have to look for two things. You will see a black dot and the white vertical line. Now the black dots corresponds to the OCT lens, and the white vertical line is just to highlight the black dot, because sometimes black dot may not be visible. So you have to follow that black dot, because it's a black dot which correlates with the OCT lens. This is just, I'll show you how live stent implantation is done by using dynamic angiocorregistration or Altier 2.0. Here you can see on my right is my reference image. I am looking at the OCT screen only. I'm not looking at the angio. My complete focus is on the OCT screen. Here on the right screen, I have bookmarked my proximal and landing zone by this white bracket. So this is the area where I'm supposed to land the stent. And now I'll place my stent. I'm placing my stent live. You can see on my left screen, I'm placing my stent. I'm seeing the right reference image on the OCT screen only. You can see. So this precision you can do. Yeah, you are not supposed to, you may not look at the angio screen, because the live screen is also visible on the OCT. Your reference image is also on the OCT. Where you have to place the stand is also already highlighted or marked by the white brackets. So I'm that area, I know I have to land my proximal area here, distal area here. So I just mark that stand looking at the OCT screen only. This you can see, this is live angio, this is the angiocorregistration. An entire thing can be done using the OCT screen. Similarly, in post-dilatation also, once I've done the OCT, I've seen that this orange is my area of under expansion. This I have marked as my reference image. So I know that this particular area is only under expanded. So what I'll do is I'll take a post-dilatation balloon and I'll focus on that area only, which has already been seen on the OCT screen on my right side. That this orange area is the only area which is under expanded. So I may not do post dilation on the entire area. I'll focus it only on that particular point, which is seen on the OCT screen itself, which is on the right side, that yellow marker. And this is the area of under expansion. I'll take my balloon and I'll see a live OCT screen on my OCT screen, that post dilation balloon, and compare it with the reference image on the OCT and see for the on that orange segment. So the post dilatation can also be done using dynamic angiocorregistration for a precise post dilatation, and so that you can focus your resources and at that particular segment only. So this saves the time, because you may not do a complete post dilatation. You have to do only because the rest of the stand is expanded. So you have to do only post dilatation on that particular segment. This entire thing can be done using dynamic angiocorregistration live on this OCT screen. Now, fourth is stand expansion. This is the main what we desire in any imaging modality. And for Ultron 2.0, assessing stand expansion is very easy. We need to understand that there are two methods for assessing stand expansion. One is a tapered method and other is a dual method. Then tapered method, it compares the actual expansion to a theoretical target based on the proximal reference selection and natural vessel tapering occurring at the side branch. So we compare our stent expansion based on this theoretical target. What we do in IIC is we compare our stent expansion MSAs based on the distal reference area or the proximal reference area. Here in tapered mode, it actually targets the vessel. It theoretically is a theoretical based target. It forms a based on these number of vessels and natural tapering. It creates a theoretical target. Based on that, and based on that, it compares stand expansion at each segment of the point. This is what we call as a novel volumetric method. So it takes into account all these branches and natural tapering of the vessel. The second method is the dual method. In dual method, what it does is it compares your distal segment with the distal reference and proximal segment with the proximal reference. The dual method, for all practical purpose, we use a tapered method. dual method is only used at that segment whenever we have a very large branch which is overlapping. So suppose I'm doing a left main to LED angioplasty. So in that, I may use a dual method, and I'll put that white cursor for demarcation for proximal and the distal segment at that point where my circumflex is starting. That means at the LM bifurcation. So then in that scenario in dual method, I'll compare my all these segments before the bifurcation of left main to my LED segment, distal left main LED, and proximal to that white cursor to that left main segment. So this is mainly used in large bifurcation dual method. Otherwise, you have to use these tapered method. And also in stent expansion, under expanded stents will be visible as orange. Orange is the color for under expansion and post OCT assessment. So this orange color will be visible on L mode as well as on your angio co-registration ACR. So that you can see that this is my area of under expansion as seen on the L mode as well as on the angio. So now you can focus your entire post-dilatation strategy on that particular segment, which will be visible again on as an orange color on the OCT screen. So these AI features, this angio co-registration, stand expansion is very easy. You can just do the OCT pullback. It show you where is your stand is under expanded, and at that moment you can do post-dilatation, and you can again do an OCT to confirm that whether your stand is fully expanded or not. In IVUS, the problem is in IVUS there's no such AI features. You have to compare, you have to manually measure the MSAs at all these segments, and you have to compare it with the distal reference and proximal reference, and then calculate your expansion, relative expansion manually. You have to do that. But here it's all AI based, and it all automatically calculates your whether stand is expanded or not. Another feature which is very useful is 3D bifurcation with Ultron 2.0. This has improved much as compared to Ultron 2.0. In 3D bifurcation, it provides an immense view to see a 3D bifurcation mode. What you have to do is click into the mode through the context menu in the cross-sectional view or the lumen profile, and then you can customize what you want to see on the screen by the display content menu. Suppose I want to see the lumen, I want to see the tissue, I want to see whether both these vessels, all these things. So it selects what you want to see in the 3D bifurcation view. You have to see both these wires, frame indicators, cross section, and everything can be customized. So once you have done this, then it allows you to easily switch between the ostium view and the carinal view. That means you don't have to search for where my in 3D, where is my LED ostia and where is my carina. You just click on the ostium view or the carinal view. The software will automatically takes you where is the carina and where is the ostium. And also, if you click the close button and tilt, and it will take you to the fly-through mode. You can go inside the artery and you can see the fly-through mode. Just for giving the example, I'll show you. This is the 3D bifurcation from left main to LED angioplasty was done. And the beauty of this 3D bifurcation is you can see the live angio simultaneously on the screen. You can see the cross-sectional view simultaneously on the screen. You can see the L mode simultaneously on the screen, as well as you can see the 3D bifurcation. So there I'm assessing whether my circumflex is well open or not after the provisional stent strategy. And I know where's my OCT marker. You can see, I'm seeing my live angio also here. I'm seeing my cross-sectional view. Everything is visible on one screen in 3D bifurcation. So that correlating your 3D findings with OCT is far easy with Ultron 2.0, because such features were not present in Ultron 1. Ultron 1 doesn't show a live angio and cross-section simultaneously, but here everything is visible simultaneously in 3D bifurcation view. So just the live, I can see this is I'm assessing circumflex ostia after doing a final kissing balloon in a provisional stent strategy. Now here you can see my circumflex ostia is very well open. There are no struts across the circumflex area. There are hardly any struts visible. Well opened very circular opening of the circumflex. No stent struts visible. So this gives us a good assurance that we have done a good provisional stent strategy and have done a good final kissing balloon inflation, because I see a very good open of circumflex and I see a very without any stent struts. Also, you can easily find out whether I have done a distal cross or a proximal cross. We know that in provisional stent strategy, we always desire for a distal cross. Assessing this on angiographically on IVUS may not be that easy, but with 3D bifurcation view, you can easily see whether I have crossed distally or proximally. Here you can see on my left screen, this is to illustrate that the crossing is distal. This is to a right side. This is to illustrate that crossing of the wire is proximal. So this can be easily seen on 3D bifurcation view. Lastly, I can say there's an option of compare pullback. This is a very good option to show your result to your patient, to your referring doctor, that this was the pre-post procedure, this was the pre-OCT MLA, this is the post-OCT, my MLA is increased from this to this, my expansion is also this much amount, my post-MSA is this much. Everything will be concise. You just do the compare, switch to compare pullbacks, and the software will automatically analyze the pre and post, and this will give you one screenshot. So you can save this screenshot and send it to your physician, patients, or any relatives. So showing that will be very easy for you, and patient will also like, this is my pre and this is my post and this is my stent expansion. Everything is, when this is just on a one click button, and the software will automatically build this slide form in your, and this for the patient. Lastly, also there's a feature of customized pullback, customizing your profile in Ultron 2.0. Suppose there are multiple operators, as in Vedanta and Escort, there are multiple operators, about 15, 20 operators. What with the customized profile you can do is, each operator can customize his own profile. Suppose I'm mainly using a 50-50 saline, 50 OCT, 50 dye. So I can customize this on the software. So this can be customized. I'll show you how. It has all these features. Suppose I want to do this, all this can be customized, whether I'm a pullback variety 54, 74, what is my threshold for expansion, because somebody likes almost 80%, somebody likes 90%. This can be changed. A position threshold can be changed. OCT color map can be changed, and this can be saved. The saved profile will be available to select when the beginning a new case. This can be saved once, and whenever the operator clicks that I want to do this, this can be automatically switch to this operator profile. So this multiple operators can choose their old profile, they can customize, and they can save for future use. Last, just to decode the colors of Ultron 2.0, it is a very colorful software. So one must be well versed with all what each color donates. Suppose in this L mode, if you see these white dots indicates major branching and branching points. Orange in pre-OCT pullbacks indicates calcium. White dotted line indicates EL. On cross-sectional view, this white dotted line again indicates EL. This triangular structure in the cross-sectional view, white, it indicates the maximum, where is the maximum thickness of the calcium. On angio co-registration, this white dot indicates a marker for the lens, and this black dot indicates a lens marker. Similarly, in the post, yellow indicates malapposition, green indicates underexpansion, and in the angio co-registration, in the post, if you see these white brackets, white indicates where is the stent. White is complete stent co-registration is visible in the white. It highlights where the stent is, and on the orange in the angio co-registration in the post indicates site of underexpansion. So all these colors one must be well versed with to maximally utilize this software for a better patient outcome. I think the information which OCT Ultron 2.0 gives to us cannot be imagined with angiography alone. Thank you. And the future, the last slide about the future of Ultron 3. What is Ultron 3.0 is bringing to us? It is bringing three important features. First is the automatic digital co-registration. In Ultron 2, we have to do manual co-registration. It is not digital. Here will we get digital co-registration. We will get a faster pullback. Within 1 second pullback. This will increase the faster speed will lessen the dye and will increase the image quality. Also, it will come with a virtual FFR. That means in the OCT pullback, we can do an FFR also, VFFR. This will be inbuilt. All three features will be there. And also fourth feature will be automatic tick-for detection. That means automatic lipid detection will be there in Ultron 3.0. I think these all four features will be again a very useful thing whenever the Ultron 3.0 will come to us, which will this feature will help us in further refining our results and improving our patient outcome. Thank you for your patient listening.
Well, thank you, Pankaj. It was very illustrative. I think you brilliantly showed how vast are the features in Ultron 2. So I think this is wonderful, and you also showed the future. So before that, I initially forgot there is another expert on the panel, Dr. Pothiwala, who is the director, Department of Cardiac Sciences, Sterling Hospital, Ahmedabad. So welcome, Dr. Pothiwala. Dr. Pothiwala is again a very dynamic interventionist and doing a lot of imaging besides the structural work, well known. So welcome, Dr. Pothiwala. We seek your inputs also. I'll speak few lines and then I'll seek your inputs before moving on to the rest of the speakers. So Pankaj, it was very good, and I agree. After using this, there is a huge feeling that what we were missing initially while we used to do PCI without these imagings. So many times, we take three OCT pullbacks, four OCT pullbacks because we're not comfortable leaving the vessel like this. There are certain underexpanded areas. There is small dissection at some point, so there is a small dissection at the proximal edge versus the distal edge, whether we should leave it, we should have it. At times we have seen that our area of focus is somewhere else, but then a lot of length prior to that lesion, there is small dissection lying. I mean, there is a dissection lying and we can't leave it. So it requires additional stent, and that's a spontaneous dissection. So I think it is giving us a huge overview, which has changed our practice in a brilliant manner. And we are actually waiting for Ultron 3, which will be some add-on features like TICFA, Pankaj has mentioned, the lipid. It is giving us a depth of calcium, Ultron 2. But then we are looking at the depth of calcium and what kind of depth of lipid and what kind of lipid we are dealing with. So it will be great in knowing all these features and preparing ourselves and doing intervention accordingly. Dr. Pothiwala, I'll invite you for certain of your inputs. Dr. Pothiwala, are you around? Can somebody check, Jasprit?
Krishnaraj, can you please
Yeah.
confirm it?
Yeah, we can see you now. Dr. Pothiwala, welcome.
Yeah. So first of all, congratulations, Dr. Pankaj. You have elaborated in a very nice manner. Honestly, all basics are there. Uh, for me, OCT we have recently used since last 3 years. Initially, we are IVAS guys, but when I have used OCT, I see a big difference. Very big difference. And for me, besides these 7, 8 features, the vulnerable plaque. So recently we have detected so many vulnerable plaques and we treat it. And even studies now there, it is superior than the FFR also. So we have detected vulnerable plaque a lot and we treat it. And believe me, the patient symptoms just vanish off. So vulnerable plaque is one of the best modalities, which is, OCT can detect in a much better way than even IVAS. Second is the nodular calcium. Even in any form of calcium, OCT is step ahead than the IVAS, particularly nodular calcium. And I have, 2, 3 cases which I can show if time permits. We miss nodular calcium on IVAS. First, we have done on the IVAS, we put the stent, and suddenly nodules protrude inside the lumen. And when we perform the OCT, then and then we came to know, okay, it's a nodular calcium, and we treat it with IVL, and then other things, it's a different thing. But so gradually, I switch my all intervention from IVAS to OCT.
Same. I think this is a brilliant comment, and I tell you, our experience, we have both. We have both, and we have a IVAS where the angio co-registration exists with IVAS also. But I think it doesn't match the OCT. OCT is something which gives you uh, so big a clarity in everything, inside the coronary. So I believe if there is any no derangement of KFTs and not in absolute ostial left mains, if we are checking where it may be masked because of the guiding catheter, all other points, if we can use OCT, that's going to be better. So I totally agree with Dr. Pothiwala's comment. So I think in the interest of time, let's keep moving ahead for the next presenter. Next presenter is Dr. Sushil, who is with us in Medanta, and he's also a brilliant guy, very dynamic, and doing lots of interventions. And he hails from Haryana only. So welcome, Sushil. Please go on and load your presentation.
Yes, sir. Good evening, sir. Good evening, everyone. It's been a pleasure and honor to work under Dr. Rajneesh. He has guided us through all the difficult intervention, coronary as well as structural. Thank you, sir. So now I will be speaking on the benefits of a OCT in a case which looked like a straightforward LED lesion, but OCT told us something else. Without OCT, we would have left this patient with a ticking time bomb, and it could have been a catastrophe for the patient. So just please move ahead. Next slide, please. Yes. So he was a 49-year-old diabetic male who presented with acute onset chest pain since 2 days and shortness of breath since 2 days. There were ST depression in the ECG in anterolateral leads, and echo showed LV LED territory with LCX in 35 to 40% of ejection fraction. So here is the coronary angiogram. Next slide, please. So there was a mid calcific LED lesion, and there was a significant lesion in the OM also. Next slide, please. So we pre-dilated with 2.5 into 12 balloon. And then next slide. We put a 2.75 into 32 stent. And next slide, please. So after post-dilating with 3 into 8 balloon, angiography looked okay. It looked acceptable. But as Kapoor sir always say, that always check with the imaging. And we all follow that almost 80 to 90% of our coronary intervention are imaging guided. So then we took the OCT shot, and yeah. So this is the OCT, which showed significant dissection in proximal and distal and along the distal stent edge. The proximal dissection was 2 millimeter before the stent. It was probably because of the guiding catheter, and arc was more than 60 degree, almost reaching to 180. Length was also 8 millimeters. And angiographically, we initially planned only to stent the mid LED, and we opted to left out the distal segment lesion. But when we did the OCT post stenting, then it also revealed there was a significant critical fibrous lesion with with the area of only 1.6, and there were these two dissections. So OCT changed our management. So after this OCT, this thing, we changed our strategy and we covered both the dissections. Next slide, please. Then distally, we overlapped with the 2.5 to 28 millimeter stent. Next slide. And proximally, we put a 3 into 9 millimeter stent, overlapping with this previous stent. Next slide, please. We dilated with 3.25 into 6 balloon. And then we checked the final OCT pullback also. Next slide, please. So now this entire dissection was well covered. The MSA was 8, 7, and distally it was 5.3. There was no dissection. Stents are well apposed. No malapposition. And the OCT saved us. Not only the patient, but also because when we felt that and it was acceptable, but OCT made a huge difference in this patient's outcome. And this was the final shot. Please run again. So without OCT, please run again. Yes. It's not coming clear. Final slide, please. Last slide. I think it has encountered some problem. Last slide, please. So without OCT, only based on the angio, we could have missed the dissection. But with OCT, we got supervision. We caught the dissection and fixed it. So ultimately, OCT is not a luxury. When angiography says fine, OCT says look again, and it tells us see more, look more, and do better. Thank you.
Wonderful, Sushil. It was a very good presentation. And I think I'll invite Pankaj and Dr. Pothiwala both to give their comments on this, and then we can go ahead.
I think excellent case, Dr. Sushil. I think one thing, I think what I would have done, you didn't do the pre-OCT for assessment of the size of the stent, the plaque burden. You should have done that.
Yes.
Had you have done that, you would not have got a surprise and the post OCT pullback. So always you do the post, but once you have opened the OCT, it's better to utilize it completely. Do the pre-OCT, see for the distal landing zone, proximal landing zone, plaque burden, everything. So it
Yes.
will, you don't see surprise in the post OCT pullback otherwise.
Yes. Exactly. So we would have done the pre and would have changed the strategy and covered the distal lesion also. But the most surprising part was the proximal dissection, which was very huge, and which changed when we were very shocked also to see that.
That must be guided because it was far away from the.
Yes.
So it was.
Yeah, it was.
I didn't see a dissection distally. There wasn't any.
Yeah, there was a small dissection distally.
But that could have been left alone also distally dissection.
But then that distal lesion was also there, and we initially when we thought to leave that lesion, but when we checked the OCT, the area was only 1.6. So we could have left the dissection, but then taking into consideration both the points, so we stented that distal segment, covering the dissection as well as the lesion also.
Can be tricky.
Yeah, it could have been better if we'd have done pre. Usually we do pre also, but here we thought angiographically it's okay-ish lesion, nothing to expect, and then we went ahead with the stenting.
It's really a very nice case. Sometimes you know what happens if during OCT, if you forcefully inject, this dissection maybe during the, while you are taking the OCT run. If you see, sometimes there is just not ventriculization, only ventricle, not damping, but ventriculization, we just inject very fast. It may lead to dissection. It may happen sometimes. So I always teach my junior that don't do fast injection if there is a even ventriculization. So we can avoid such catheter-induced and dye-induced or forceful-induced dissection. So if you run even pre-run, you can find the distal very well. Distal lesions for there, you might change your strategy upfront distal cover and the proximal cover.
Yes, sir.
But this dissection seems to be while you are taking the OCT run. So pre-run, you may not found any dissection on the proximal part.
Yes, sir. Yes, sir.
Yeah, agreed. Valid comments. So many times, I think, as Sushil has already mentioned, we use pre-run stent and the post-run. But at times where you feel you can just get away, it's a small looking lesion, only in the mid, there is good landing zone on angio. So that is where, the angio landing zones are different from OCT landing zones.
Yes,
Over
sir.
the time, we have realized that, what OCT tells us is a different picture. We can't really depend upon in vessels like this where there's a diffused plaquings all across. So angio may not be giving us a real picture. So and then proximal dissections, I think it happens while because of the overhang of the balloon, and if especially there is small plaque we are starting, landing zone is in the plaque, and that overhang balloon of the stent can lead to these dissections.
Yes, sir.
Okay, so well done. We have one more presenter here, and Dr. Shekhar Kunal. Dr. Shekhar Kunal will be presenting one more case-related presentation. He's Associate Professor, Department of Cardiology, ESI Medical College, Faridabad. Dr. Shekhar, please go ahead.
Yeah, good evening, everyone. I hope my slides are visible.
Yes, yes.
Yeah, so I'll be speaking on precision revascularization, image-guided hybrid strategy. So we have this male, a 55-year-old hypertensive male. He presented with angina on exertion, had a CCS class 3. He was on OMT, albeit no relief. Now, he has a prior history of coronary artery disease. Revascularization was done to LAD 7 years back. At that time, he had a triple vessel disease, and LAD lesion was around 90%, with LCX lesion around 50%, and RCA was a total occlusion. And at that time, a viability testing was done. RCA was non-viable, so they had just gone for a PTCA to the LAD. So routine labs were within normal limits. ECG was in sinus rhythm. Q waves were in 2, 3, and AVF. Echo had inferior wall akinetic with an EF of 45%. TMT was strongly positive for induced tubal ischemia. Viability testing done previously, there was a non-viable RCA territory. So going over to coronary angiogram. So here we can see a lesion in the circumflex, and we can see a stent in the LAD. On a cranial view, you can see in the mid LAD, there is some amount of ISR with very tight segment, and just distal to the stent, we have some degree of calcium with a retrograde filling of RCA. The iliocaudal view, where you have some ISR in the LAD with a diagonal which is diseased, and an RCA which is totally occluded, and RCA was a non-viable territory, so hence we decided to first go on to the LAD. So we crossed the lesion with an green wire, a BMW wire, and then we did an OCT pullback. So this was the OCT pullback for the LAD. So this is a portion which is distal to the stent. We have dense calcium, nearly 270, more than 260 arc. Then we have the stent struts with neoatherosclerosis with both fibrotic as well as calcific lesion in the LAD. So this was the distal portion. We had nearly a 360-degree arc of calcium, and both the lesion in the neoatherosclerotic lesion in the stent, and the minimum area was 1.74 millimeter square, and we also had some degree of calcium in the stent segment with a good amount of fibrotic lesions. So it was both fibrocalcific ISR and in the lesion. So then we thought that we should go either with the cutting or a scoring balloon. At that time, we didn't have a cutting balloon with us, so we went with a scoring balloon 3 into 10 mm, the LAD stent, as well as just distal to the stent where we had the calcific segment. And then we did an OCT pullback post scoring balloon and high pressure dilatation. Here you can see the multiple cuts. We can see the fractures are seen in the calcium segment, and we have achieved some degree of good luminal gain with balloon dilatation. Once again, just going through. So here we have a good fractures obtained in the calcium. It's just distal to the stent strut. So here we have the cracks in the calcium distal to the stent strut where there is thick calcific lesion, and we achieve a good expansion with an area approximately around 4.6 post balloon dilatation. It also did a high pressure balloon dilatation in the stented segment. So we plan that the distal portion of the stent, we go for a stent of 2.75 into 18, where the stented segment we would just go with a DEB of 3 into 15 mm. So we just deployed a small stent distally, at the distal edge of the stent. And this was a angiographic result post the stent deployment in the LAD in the distal portion. And then we did a paclitaxel luting, DEB in the proximal portion. So the final angiographic result, which is a good TME3 flow, good expansion. And then we did a post PCI OCT run. The stents are well opposed distally, and we have achieved a good luminal area, and stent expansion was around 98%. And at the end, we achieved a good result with both combination of a scoring balloon, stent, and a DEV in the proximal segment. Thank you.
So it's a nice case, and you showed this the calcium, peristent calcium also, and new atherosclerosis. So very well managed with DEB, and I think this is also upcoming. That lot of DEB usage is going up, and we have now learned to do DEB in de novo lesions also and leave it. So there also, I think it's a OCT imaging. So imaging is making us bolder. Imaging is making us audacious in taking the decisions. If there are no very badly looking dissections, we can actually leave such vessels even without a metal. So Pankaj and Dr. Pothiwala.
Yeah, I totally agree, sir, with Dr. Kapoor, sir. Imaging should be mandatory when we are doing a DEB, because to proper assess the vessel size, to see for the bed preparation, and to assess the dissections, whether this vessel will close or not. So imaging can give you a good insight as to whether this dissection is going to close or not, and whether I'm supposed to do a bailout stenting or not. So whenever I DEB, and I think imaging is essential in DEB, very, very essential for a good vessel preparation, everything at each point of time. I think it is very, very essential, and particularly in when we are doing deep, because we don't want a vessel to close. Sometimes we are confused. We see a dissection, whether this dissection is going to close or not. So we have various criteria of depth dissection, what we have to stand, whether we are not, we have to leave. I think it's a very good modality. Particularly, I think depth is very, very good modality when you are doing a depth.
See, whenever we do DEB, we prepare the bed aggressively and then do the DEB. So very clearly and without doubt, we are going to see dissections.
Yes.
So this is what actually is happening. This is what we are doing, to open the vessel.
Yeah.
It is going to show you dissections. Now, dissections can be very bad where the flap is just revolving in the vessel, or it's a circumferentially covering the whole circle or the small. So we have done few cases like this where we have done DEB, but then we have done the imaging and we have seen there is a small part where the dissection is very hostile. It is looking very, very bad, and rest of the dissections we'll accept. So we have done a small stent and rest 40 millimeter or 50 millimeter DEB vessel only with the balloon. So I think it makes us wiser, and we are learning a lot of things with imaging, that which are the main hostile areas where you require a different intervention or a blended intervention. You can have a small stent and rest all the DEB. So all these things are picking up, and I think we'll have also the data regarding this, the blended PCI, I would say, small stent and rest of the DEB in diffuse disease arteries. So Dr. Pothiwala, your comment?
Yeah, it's true for the native vessels. We have to always go with the image modalities. I have few experience in the instant stenosis. Recently, we have just young guy who is having left main bifurcation and got the severe angina, troponin positive, and instant stenosis. So it's almost left main bifurcation. So we did OCT. It seems to be hyperplasia, smooth. We did cutting balloon. After cutting balloon, because even if we see the this slide also, there is a few dissection even in the instant. So it's because of the scoring balloon, and that there is a crack as well as few dissection flap, because there was significant instant proliferation. So even if you do DEB, like this case, he has performed a very good DEB in the instant stenosis. I think dissection, we can leave it. This is what my personal opinion, because I have done many cases in such a day, and all patients are doing well. Few patients are even crossed more than 1.5 years also. So this is my personal opinion. If we are having dissection, instant stenosis inside the stent, dissection, no flow limiting, you can go with the DEB and you can leave the dissection like this case. Yeah, native vessels, if there is a dissection, use dissection flap, flow limiting, intramural hematoma, we should go with the stent.
Agreed. Totally agreed. Pankaj?
Yeah, I think there are two important features. I think the way we see dissection at the distal edge of the stents are different from the way we see in the native vessel when we are in web. In dissection, whenever we see a more than 60-degree arc or the length is more than 3 millimeter, we place a stent. But in depth, we can leave these very thoroughly. There are two important areas in which we have to do bailout stenting. First of all, is the dissection is accompanied with intramural hematoma. Intramural hematoma is a sign of impending vessel closure because there is a false lumen which can compress the two lumen. So whenever I see intramural hematoma along with the dissection, when I'm doing depth, I also go for a bailout stenting. Intramural hematoma is the ominous sign of impending vessel closure. Your vessel may, because intramural hematoma can expand and can compress the two lumen. So whenever you see an intramural hematoma, you always have to stent it. You can't just leave it, leaves intramural hematoma. And secondly, if I see a dissection in the absence of any vessel expansion, my vessel is not expanded, but still I'm seeing a dissection, then that vessel can also close. So absence of vessel expansion and the presence of intramural hematoma are two signs in which you have to do bailout stenting whenever we are doing a depth.
Very nice. So I think these are all the pearls which everybody, all of us should remember and apply in our practice, which we are routinely doing. So we actually focused on OCT, Ultron device, and I'm sure we are looking forward for the new device, the Ultron 3. It's going to be even faster, and I liked the Pankaj's penultimate slide, where prior to the Mahatma Gandhi slide. That was good. And overall, I think we keep learning with everyday practice in more and more cases. So definitely there is no doubt that imaging with OCT has uh, improved our practice, and more than that, the outcome to the patient. So we don't want, and see, I think, look at the stent thrombosis which we used to see 10 years prior or 5 years prior without the imaging. So I think the stent thrombosis have gone down, and the reason is imaging. So we should definitely be proactive and not shy away from doing imaging in most of the cases. And it is clearly seen that it is a class 1 indication, although there is some recent trial which
NEJM trial,
yeah, which is
I
raising.
don't think they are so much relevant,
Yeah, so
because we
same.
see, day to day, benefit with the imaging, and they say there is no difference between IVUS guided and angio guided PTC.
Absolutely. So I think in all complex lesions, all left main lesions, all osteal lesions, all diffuse disease lesions, calcified vessels seen on angio, imaging is very, very important. So with that, we can close this session. Thank you, everybody. Thanks to Abbott, Sunil, Jaspreet, everybody put in the hard work. And thanks, special thanks to Pankaj, the dear friend. We keep planning some of the excursions together. And thanks to Dr. Potiwala. So we invite you to
Forward to
some
that.
meetings. You should
Looking
come.
forward
We
to it.
send you an invite. Please be there.
Yeah, sure.
Okay. Thanks.
Thank you, everyone. Thank you,
Yeah,
Thank
sir.
thank you.
Thanks a
Thank
lot.
you. Yes.
Good night.
Thank you. Thank you.